We're going to talk a little bit about how to see the Asian patient first and then how to treat the Asian patient. So I think actually both components are equally important. I don't want to discount either one. The first most important thing that we have to consider are cultural issues. A lot of times you come in and you just look at the aesthetic component, but you're not looking at the whole person. This can be even important for people that are second or third generation individuals. I just had a consultation with a gentleman who said, and you know, Sam, or Dr. Lam, you know that I actually, I can't do this until I get back to Vietnam and talk to my fortune teller about this, and I bet you never heard of such a thing. And I quoted him from my clinic's article. He goes, I guess you heard about this. So actually it's interesting that some people do this for not just aesthetic reasons, but for cultural reasons, because a large nose, large ears can actually be associated with wisdom and wealth. However, you got to be very careful too. There's other components as well where the visibility of the nostrils, if they're rotated upward, we're going to talk about some ways to protect against that, can also make someone feel like they think they're going to lose their money, which sounds insane to you guys, but in fact it actually is a large component. If you don't ask for it, you may find that the only reason they're doing it is non-aesthetic at all, and is cultural. So you got to delve into some of those things and make sure that you are going to satisfy this patient. The other thing that's really a core issue with this discussion is not necessarily westernization, but I think the operative term today is preservation of ethnicity, particularly very high raised bridges, very contracted Ayla. They may look good on a Caucasian, but there's something unmistakably unnatural when you see a patient, when you use standardized Caucasian ideals for your results. Instead of looking at the radix being at roughly at the superciliary crease or the top of the eyelid, I look at a little bit more of a conservative nasal profile that rests somewhere at the mid-pupil. If you look at a lot of the Asians that have a very low bridge, oftentimes it starts relatively at the base of the eye. So I'm shooting for roughly to mid-pupil as a rough idea. The tip also, you know, a lot of Asians, you know, a lot of times we keep on pushing the idea of tip projection. The question is how much, and how much does that Asian patient actually want? And exactly how much definition do you want? We're going to talk about different strategies to achieve either a softer contour or one that's a little bit more defined. What are the strategies that are used out there? A lot of them, and I've gone through all of these things, but I actually have limited some of my injections and rhinoplasty techniques down to certain ones. I'm going to talk to you about how I do that. I don't use silicone implants anymore, solid silicone implants. I think that some of my colleagues in Asia have gotten some very good results and long-term 20, 30-year results that still look very good. So I'm not here to condemn it. I think it's very easy for us to condemn a technique when perhaps in our hands we don't get the right results. I saw progressively greater problems with it in my hands, and I decided that because of the things you see listed here, that it wasn't something that I wanted to offer my patients. It just, in my hands, didn't look very natural. And oftentimes, this is a lady that has a silicone implant. I just took out the implant. Now, you can see she looks much, much better by just taking the implant out. And oftentimes, it's just an office procedure to take out the silicone implant through a small little vestibular recessed incision under local. And the benefit of it is oftentimes as you bring the nose back down to about halfway from where it was originally to where it is currently. The major risk of doing this procedure, as we heard from Dr. Daniel, is actually having this nose shrink wrap over time. So you want to make sure that you wash this patient and decide whether in fact this patient is a candidate for a revision nose. And also to make sure that there isn't any kind of crush injuries from the silicone implant, you've got to inform the patient of that possibility. So the longer time this implant is and the harder that implant is out of material, it can actually create some pressure necrosis on the underlying cartilaginous and bony structures. This is a lady that had a silicone implant in Vietnam. It had already extruded through, and I used Goretex and tip grafting, and then I did a reconstruction of the base of the skin. What are strategies that are outside the sort of the common thinking of rhinoplasty? Well, it's injectable rhinoplasty. Does it always work? Is it consistent? I do a ton of facial fat grafting. I do very little in the nose. And I don't do this as a separate standalone procedure, someone coming in for rhinoplasty. But if they've got an inverted V, a shrink wrap nose, and I'm going to do a facial rejuvenation with fat grafting, I think it's an easy 20-second procedure to try to put some fat grafting to cover the area. The limitations of this is, one is that, you know, fat grafting is a live graft, and you want to be careful with offering a patient something where it could potentially change over time. So I'm very conservative, and I'm just trying to cover up that shrunk down skin envelope. Plus, the blood supply of the nose is not perfect. So you really want to be careful in offering a patient fat transfer to the nose to correct something. But if it's something that they didn't pay for, that you're just putting a little bit in there, I think it does help a little bit. Here's a lady that's about 6 weeks out from a facial fat transfer, and we'll follow her over a year period. This is, hold on, let's see if it goes forward. 6 months out, and you can see in her case is retaining quite well, and you can almost see that you've covered the bone, which is really the key element in this rhinoplasty or also fat transfer. And then this is 14 months out, still retaining pretty much the dorsal height. Does it consistently occur? No. But I think this is a nice adjunct if you're doing a fat transfer, and you want to be very careful. I usually limit the amount I put into about half a cc to a little over 1 cc, not much more than that. And it's really for dorsal changes, not for tip changes. I do silicone injections. I do quite a few of them. And you know, the thing that's very interesting, I was listening to a lecture in St. Louis, and you know, what's very interesting is we all have silicone in our bodies. Diabetics, every single needle that you inject a patient with is coated with silicone. Every single blade you use has silicone on it. Patients have silicone in their entire bodies. Diabetics get about 2 to 3 cc's of silicone injected into their bloodstream per year. So I think there's a great fear of it, because oftentimes, I think we're going to hear from Dr. Duffy, a lot of problems with it if you're not using it the correct way, using microdroplets. I don't use radius anymore because I use silicone. And I think radius injections are good for the nose so long as you're not planning a future rhinoplasty. Otherwise, you're going to have a heck of a time getting in there. The tissues get pretty scarred down. The strategies I use are Goretex and Cartilage, and I think Goretex is nice, and I haven't had any major problems so far with it. I really like it because there's, as we heard, there's not much, you know, enough cartilage to do the job in terms of raising the bridge, unless you're using rib or extensive conchoidal cartilage to actually raise that dorsum. And the Goretex just doesn't have the weight that silicone does, and I tend to like the sheets more than the actual solid ones, the blocks. And it doesn't tend to shrink wrap as much as silicone. As you probably know, that the Goretex is off the market by W.L. Gore, but if you want to purchase them, both Implantek and Surgiform now make the sheets and blocks. The one I've had experience with so far is Surgiform. I usually use the ones that are 1, 2, or 3 millimeter preformed sheets, and then I just trim and cut them and crimp them into position. So what is the technique I use? I use open rhinoplasty in the majority of cases, and I use the SAM sheets, or that's the term that Gore used, and crimping the edges. I use a little target at the base to ensconce down between the medial crura. And I find it to be a very expedient, effective solution to get a smooth dorsal height without a large risk of shrink wrappage of the dorsal shape compared to silicone. In the tip, I prefer septal cartilage, and if I don't have enough, I use conchal. The thing that I really want to emphasize is that the thing that I've found in my hands is that a dome-binding suture could actually be problematic in many cases. The reason being, as I was talking about, is that the major concern that a lot of patients have is nostril show, and when you start to bind the tip together, you can get a little bit of undue rotation. Even a couple degrees can actually exacerbate nostril show, and that's something that's not great. What I prefer instead to create tip definition is to use, instead of a reductive type of tip dome binding suture, is to use a standard shield graft if you want to get better definition. It also helps to address the issue with premaxillary deficiency, because the problem is low down. When I look at the congenital Asian nose almost like a type of polybeak, because you get a very full super tip contour, a relatively low nasal profile, almost as if the bone was over-reduced, and then you've got a relatively recessed premaxillary area. So by bringing the premaxilla down, taking some of the supertip fullness down, and raising the bridge gives you an overall better, I think, profile contour. And then we heard a little bit about alar base reduction. I'm going to address that just briefly in a different light. Alar base reduction, and we've already heard about the sheen. That's exactly what I do, either a sheen or a nasal sill in isolation. I've tried the cinch sutures, they don't work. The thing that I really want to have you understand is something that hasn't really been addressed in lectures, which is the balance between the lobule and the ala. Oftentimes the patient coming in wanting the ala reduced have very tiny flimsy ala and a really central lobular component. And that's very much the predominant features that occur in most East Asians. And so if you do an alar base reduction for them, they actually exacerbate the quality of their lobules. So you want to be very careful in not actually exacerbating the balance between the alar base and the central lobular tip. This is just showing you the Goretex SAM sheets. This is actually a Goretex, but again, Surgiform and Implantec make those as well. I have no final